All right, let's continue. We talked about the basics of electrical communication within a neuron. We talked about the basics of chemical messaging between neurons. But I think it's important to talk about the neurotransmitters themselves because the neurotransmitters affect a lot of our psychological well being. So, if you take a course on mental health or psychopathology, you will see neurotransmitters at play in all conditions. Now, other functioning, you'll see that aside from just mental health, it also affects other aspects of who we are, like pleasure, addiction, memory. There are a lot of different things that neurotransmitters impact. And researchers have found several dozen neurotransmitters, but I'm going to focus on what's referred to as the big six. Now, the big six, as we call it, refer to acetylcholine, norepinephrine, dopamine, serotonin, GABA, and glutamate. And these six neurotransmitters are responsible for the vast majority of our psychological functioning. Does that mean that there aren't other chemical messengers like hormones and peptides and things like that at play? Of course, they're at play, but we're going to focus on the big six for now, and then I'll talk a little bit about peptides. All right, so let's get into it. When we talk about acetylcholine, it's oftentimes abbreviated as ACH. And acetylcholine is found both in the central nervous system, which is referred to as the brain and spinal cord, and the peripheral nervous system, which is how the rest of the body functions outside of the brain and spinal cord. Now, if we were to think outside of the brain, acetylcholine is responsible for functioning of muscle flexion and extension, right? So muscle movements, acetylcholine's very much involved. In the central nervous system, we see that acetylcholine is involved in things like learning and memory. So if you were to take Alzheimer's disease, for example, uh, one of the findings or explanations of Alzheimer's disease is an undersupply of acetylcholine. So the neurotransmitter that's responsible for learning and memory, you're not getting enough of it. And there are a lot of pharmacological interventions like Aricept, which is a drug that's used to help treat Alzheimer's, which target acetylcholine. Now, interesting, where are we with our Alzheimer's research? We have these medications, but these medications don't cure Alzheimer's. They don't reverse Alzheimer's. They just slow down the progression of Alzheimer's typically. So if you're interested in neuroscience and you're looking for a challenge and the potential to win a Nobel Prize, take up research on Alzheimer's. Because if you crack the code in a meaningful way, that will be revolutionary. So that's acetylcholine. Then we have a series of monoamines. Now, monoamines, let's break down the word. Mono means one, amine is amino acid. So there are three major monoamines that we talk about: norepinephrine, dopamine, and serotonin. Let's talk about it. Norepinephrine, also referred to as noradrenaline, is linked to things like attention, alertness, arousal. But from a mental health point of view, norepinephrine is also linked to mood disorders. So if a person has too much norepinephrine, it's an excitatory neurotransmitter. It could lead to manic states. And if a person has an undersupply or too little norepinephrine, it could lead to depression. Now, if you were a psychiatrist and you were prescribing an antidepressant, you would say to me, hey, wait a minute. The first line treatment of medication are what's called SSRIs, selective serotonin reuptake inhibitors, right? So serotonin is also linked to depression. And in fact, there is a switch theory, which suggests that serotonin is implicated first, and depending on the combination of serotonin and norepinephrine will dictate whether you have a manic episode or a depressive episode. Now, dopamine. Dopamine is linked to movement, learning, attention, emotions. It is where our pleasure pathway operates in terms of chemicals. So things like addiction are linked to dopamine. But dopamine is also responsible for movement, right? So if you were to think of something like Parkinson's disease, Parkinson's disease comes with uh, motor tremors, jerky movements, sometimes rigidity, and it's due to an undersupply of dopamine. So if you have too little dopamine, you become rigid. And I can't remember which streaming service it was, but there was a documentary by Michael J. Fox, which is a very big advocate for Parkinson's because he suffers with it. But he basically, you see him functioning and you see his day to day and how he has to take his pills, which, interesting to note, the classic one is called levodopa. Well, L-dopa or levodopa is designed to increase dopamine levels in the brain, right? So, but what happens when the supplies get too low? He starts to lock up, he starts to have tremors, and it becomes difficult to do mundane tasks. So, having too little dopamine is a problem, right? But having too much dopamine is also a problem. An excess amount of dopamine is linked to schizophrenia, right? So things like the positive symptoms of schizophrenia, hallucinations and delusions, are linked to excessive dopamine. And when I say positive symptoms, that doesn't mean that they're good. Positive doesn't always mean good. The same way, if a person takes a COVID test and it's positive, you're not like, yes, I'm COVID positive. It's not always a good thing. It just means the presence of something. So the presence of sensory or perceptual disturbances are what we call positive symptoms. So things like hallucinations and delusions. Okay. So with schizophrenia, we need to have drugs to treat this excessive amount of dopamine, right? So many of our classic antipsychotic medication, right? So things like phenothiazines are designed to reduce the amount of dopamine in the brain. Now, I said to you, albeit not on the slide, dopamine is also linked to addictions. And if you were to take a drug like cocaine, well, cocaine is not inherently a hallucinogen, right? It's a stimulant. Nevertheless, if a person takes an excessive quantity of cocaine, it will raise their dopamine levels in the brain and could induce a psychotic state. So you can have cocaine-induced psychosis, right? So, and that's linked to dopamine as well. All right. Now, serotonin. Serotonin is also referred to as 5-HT. Serotonin is linked to a lot of different things. Now, When we talk about moods, we talk about um, depression, bipolar disorder. Uh, Serotonin plays a big role. But serotonin is also linked to things like eating, sleeping, and general arousal, right? So if you have too much serotonin, you run the risk of being in a manic state when we're talking about mood. If you have too little serotonin, you run the risk of being in a depressive state. Now, I said to you, if you were a psychiatrist, the first line treatment that you're going to use is something called an SSRI. It has the safest medication profile of all of the antidepressants and has the fewest number of side effects and dietary restrictions. So, what is an SSRI? Well, you probably can figure it out based on the previous lecture, right? We talked about the release of a neurotransmitter into the synapse, right? And we said there was a process of reabsorption called reuptake. So if we were to work backwards with the words SSRI, let's work backwards. Inhibits, right? Inhibits reuptake. Okay, so whatever this drug is, it's an inhibitor of reuptake. Well, what is it inhibiting? Serotonin. Okay, now I know it's inhibiting serotonin, but is it inhibiting other things? No, it's selective to serotonin. So SSRI stands for selective serotonin reuptake inhibitors. Basically, it blocks the reabsorption of serotonin in the synapse, leaving it there longer. And because serotonin is allowed to stay in the synapse longer, it allows for more time for serotonin to bind to the next neuron. And that is going to increase your serotonin levels, which is going to increase your mood. Now, we don't just have SSRIs, right? So we have SNRIs, selective norepinephrine reuptake inhibitors. So that's targeting the reabsorption of norepinephrine. But there's another class of medications that we use called MAOIs, monoamine oxidase inhibitors. Now, I said to you in the previous lecture that there are two processes used to get a chemical out of the synapse, right? One process is we mark that neurotransmitter for destruction and we break it down. The other process was to reabsorb that neurotransmitter and recycle it, right? So we talked about the reabsorption process, but what is an MAOI? Let's do the same thing. Monoamine oxidase inhibitor. So it inhibits the oxidation process. ASE is an enzyme, which means it breaks something down. So it inhibits the breakdown of monoamines. Now, going back, that means it's going to inhibit the breakdown of all monoamines. It could be norepinephrine, serotonin, and even dopamine. And we don't like to prescribe MAOIs because it's the broadest spectrum, which means that all three of these neurotransmitters can run amok in the synapse. And if they run amok in the synapse, we get a whole bunch of side effects. So MAOIs have far more side effects than SSRIs or SNRIs. So that's kind of a very brief piece. I see there's something in the chat. Yes, someone said that Zoloft is an SSRI, which is true, and they were on it for 4 months. Now, it does take some time for the bioavailability or the amount of the drug to start to become even in the system. So if a person was on something like Zoloft for a couple months, I would say they didn't even get the full effect. Now, by then, you do have the amount of Zoloft and the active ingredients of Zoloft working. It is true. Nevertheless, you need to give it some time for that adjustment. Now, there's an interesting other finding related to SSRIs. They have a warning label on them, especially for depression. When a person takes an SSRI, we see that their mood increases at a slower pace than their motivation. So, what do you do with a person who has suicidal ideations or tendencies? It very well could be that their motivation was low to the point where they wouldn't act on their thoughts of suicide, right? But because serotonin increases motivation, for several weeks you have a risk or a higher risk of suicidal acts, right? But afterwards, if after that short period of time, when it affects your mood, it reduces the risk of suicide altogether. All right. So we talked about all of these different neurotransmitters, all of the monoamines, right? I mentioned to you that some people say serotonin is at play, some people say norepinephrine is at play for depression, but there is this switch theory that says they work together. And in fact, it's serotonin that's triggered first, followed by norepinephrine. Okay, let's talk about GABA and glutamate. We talked about IPSPs and EPSPs, right? In the previous video as well. So IPSP is an inhibitory post-synaptic potential. I said that inhibitory postsynaptic potentials hyperpolarize the second cell and decrease the likelihood of that cell firing, right? So GABA is a very, very important neurotransmitter with inhibition. And we need adequate inhibition for walking, for reduction of anxiety, and so forth, right? So if we have an undersupply of GABA, we see it's linked to a whole bunch of things. Seizures. I talked to you about seizures before, right? So if you don't have enough GABA, you don't have enough inhibitory neurotransmitter offsetting the depolarization, which increases the risk of seizures. Insomnia, right? So if you have neurons firing in excess, it also creates problems with the ability to sleep. Tremors. So calming down muscle movements, right? Inhibition and anxiety, right? All excessive firing of neurons is going to be a problem for all of these. So not having enough GABA is an issue. Interesting to note that when we treat anxiety, there is a drug called Xanax, right? And Xanax operates on GABA. And remember, what is anxiety is you're having too much going on, too much neurological firing. So if I can inhibit some of those neurons, then that's what we do. And because Xanax operates on GABA, it increases inhibitory functioning, right? Another good example of the role of GABA is with alcohol. As I said, GABA is an inhibitory neurotransmitter, right? So it's designed to help you with judgment and decision making. You drink too much, it affects your decision making. And we get disinhibition because you inhibit inhibition, all of a sudden you get disinhibition. You also see people who drink a lot of alcohol struggling to walk in a straight line. Did you ever wonder why people stagger when they're drunk? Well, there's a whole host of GABA neurons in the cerebellum And when they're not operating or functioning properly, you can't get that clear motor movement that you have when you're sober. So a lot of the alcohol related effects are linked to GABA as well. Okay. Glutamate is the inverse of GABA, right? So you link glutamate as our primary excitatory neurotransmitter. So it plays a role in excitatory postsynaptic potentials. It also is linked to several issues or psychological issues as well. So if you have too much glutamate, it increases the risk of migraines and seizures. Now, in many foods, they now put a label no MSG. Well, what is MSG? Monosodium glutamate. And I underline glutamate because that is going to increase the risk of action potentials. And in the case of a person who has a seizure disorder, that's going to put them at greater risk for seizures. Now, where is MSG found? It's often found in as a salt substitute and a flavoring. So you'll find it in things that are salty in nature. So if you have cheese curls, right? If you look at the ingredients on Hers cheese curls, MSG's in there. Many Asian delicacies use MSG as a seasoning or flavor. So Chinese food, you might find higher rates of MSG. But if you're a person with a seizure condition, you need to know that, right? You need to know what the ingredients are because you don't want to increase the risk of excessive action potentials. But like I said, it's a flavoring. So anything that uses this as a salt substitute, you have that risk. All right. So those are the big six. But I said I would talk to you about peptides or neuropeptides. We're interested in neuropeptides, right? Because neuropeptides affect mental states as well. So what is a good example of a neuropeptide? Well, we talk about endorphins and enkephalins. Well, these are our body's natural painkillers, right? And endorphins and enkephalins are neuropeptides. They're oftentimes released during exercise or serious pain, but they don't have one amino acid. The definition of a peptide is when you have two or more amino acids. Remember monoamines? Well, peptides are not monoamines by definition. You have to have a chain of amino acids of at least two or more. So, but because it affects our psychological state, I wanted to give you an example of a neuropeptide, which some people refer to as a neuromodulator. Okay. So that is the lecture on neurotransmitters.